Stanford University.
It is my wonderful pleasure to be back here. I will tell you that I had such a wonderful time the last time I did this, but there are so many new advances, and it is my pleasure to make sure that you all come away with an idea that we at Stanford and the Stanford CyberKnife are continuing to forge the frontiers and create new and exciting opportunities for patients to have more improved lives. So this is just a disclosure. The company that makes the CyberKnife, I am on their clinical advisory board. This is not a paid position, but I always make that disclosure. Being here at Stanford is a wonderful place of innovation and excitement, and I've been here for nearly 19 years, and I've enjoyed every single moment of it. What I'd like to do today is first do a general review of some of the radiation terminology. I know that there are a lot of terms that are spilled here and about. I'll do a brief review of what I mean by radiosurgery and how that relates to other forms of radiation. And then walk you through a hopefully brief evolution of the CyberKnife image-guided technology, and then delve into some specific applications of particularly the applications outside of the brain. So just a matter of terminology, when we apply radiation treatment in the modern era, we're usually talking about three-dimensional conformal radiation therapy. In the remote past, radiation was delivered with very, very simple techniques, and the toxicity of the radiation actually was fairly high. Over the last several decades, we have modified those techniques and have been able to conform the radiation in a three-dimensional way so as to reduce radiation toxicity. Evolving from there is a technique called intensity modulated radiation treatment, and I'll walk you through what that means and how it's different from three-dimensional conformal radiation. And the topic for tonight will be specified based on these last several items: stereotactic radiosurgery. And when we use this type of technology outside of the brain, we say extracranial. And then there's a synonymous word that is sometimes used, and if I use it interchangeably with stereotactic body radiotherapy, I'll be meaning these two similarly. So with three-dimensional conformal radiation, this is just a slice on a CT scan through a sort of neck region. This is sort of near the teeth. This is the tongue. This is the spine. And so we've outlined an area that we think might be at risk for a tumor and shaded that in this orange color, and the actual tumor cells are outlined in this red. These glands here are the parotid glands, and they give saliva, and so we would want to protect that. However, with 3D conformal or even two-dimensional treatment, if you use very simple radiation fields, it essentially will irradiate this entire area almost homogeneously. And so even with some of these advanced techniques, you could still give a fair amount of dose to the saliva glands. One could bring in a few more radiation fields and reduce some of that dose, but this one just is for pictorial purposes. Now, comparing that to intensity modulated radiation therapy, it allows us, instead of giving the dose in a very homogeneous way through each beamlet, we actually can block some of the radiation dose, for example, to spare some of the radiation dose to the spinal cord and these parotid glands. And so these are a bunch of different beam arrangements which, when compiled together, may be able to allow us to spare some of the radiation dose to those other tissues. And so that's sort of what we've been using a fair amount of in radiation technology currently. So this is just to compare those kind of technologies with 3D conformal radiation treatment, really, and this is through a slice in the brain, using 4 different radiation fields. The main tumor is outlined here in red, but you see in this orange color, which is a fairly high dose of radiation, larger portions of the brain are irradiated in trying to deliver radiation to that tumor. When one applies this intensity modulated radiation treatment, we're able to spare some of the opposite portions of the brain in treating this target lesion. And so all of these colors correspond to very similar radiation doses. So you can see that here, this red is actually a very high dose. We're able to target the dose very precisely here to the target lesion and be able to conform the dose in the areas around that. With stereotactic radiosurgery, we're actually able to take that one step farther in the particular situation in which it makes sense. This particular treatment is different from these two, but it shows you how we're able to conform the radiation dose very, very precisely. This red area represents the tumor site. The green line represents the dose we want to give to that target lesion, and this blue line represents a lower dose, usually about 50% less than the dose at the center of this target. And so you can see that large portions of the brain are very much spared from radiation dose using this technology of radiosurgery. Now, we can't apply this to every single tumor type, but it does allow us in certain circumstances to be able to target the radiation very, very precisely to the target lesion. And so in terms of differences between radiosurgery and radiotherapy, when we talk about radiosurgery, we talk about high dose per treatment. Here with radiotherapy, we're using usually low dose per treatment. And because we're giving some of that dose spread to other normal areas, we end up having to give a very, very small dose per treatment so the normal tissues repair the injury in between each of the sessions. If we gave all of the dose in a single session, all that normal tissue would be irreparably injured. And so by virtue of sparing the dose, with radiosurgery, we're able to give the dose in a single or few sessions, so 1 to 5 sessions, rather than 30 to 45 sessions with conventional radiation. The number of beams that we use to actually achieve this is also much different. We use about 200 beams, 150 to 200 beams of radiation, compared to the 5 to 10 beams with conventional types of radiation therapy. The targeting accuracy allows us to be able to do this. So with radiosurgery, and I'll show you how that can be achieved. With radiosurgery, the targeting accuracy is very, very accurate, within 1 millimeter. Whereas with conventional radiation techniques, because of the bulkiness of the machines and some other features, maybe it's getting down to about 2 millimeters. So I haven't updated this slide. 2 millimeters, probably at the best with our image-guided techniques. And maybe even up to 20 millimeters with very, very crude radiation techniques. So with radiosurgery, because we're able to apply a very high dose, our intent may be a little different than what we've conventionally thought of. With conventional radiation, certainly we want to ablate the tumor, but oftentimes we're at a delicate balance between what the normal tissues can tolerate and what the tumor needs to be controlled. So oftentimes we limit the radiation dose. So typically our goal with radiotherapy is to give a cumulative dose that will control the tumor and in many cases be able to eradicate it. However, with radiosurgery, we really do want to try to ablate that tumor. And as I go through some future slides, I'll tell you ways in which we've envisioned this as being maybe a replacement for or a possible ability to supplant surgery in certain cases. So again, in terms of the terminology, intracranial radiosurgery is mainly confined to the brain area, extracranial in the body. We sometimes use the term SBRT, or stereotactic body radiation therapy, and stereotactic radiosurgery if it's given in 1 or a few sessions, mainly in the brain region. So this technique is used to deliver a very high dose of radiation to a specific target. and delivering a minimal amount of dose to the surrounding tissue, and we believe it's highly effective in tumors. The main hallmarks of radiosurgery in general, and CyberKnife is just one form of radiosurgery, is that it's highly precise, which means that one can continue to deliver a similar dose to a similar target in a very precise way. It's very accurate in terms of where you want to deliver the dose is where the dose goes within a error range of about 1 millimeter. There's rapid dose fall off at the edge of the target, so that if a target is embedded in normal tissue that needs to be spared, that radiation dose is not exposed to those areas, or very little dose is exposed to those areas. And then it's highly conformal, and that also reiterates this sort of fall off, meaning that the dose can conform to the shape of whatever your regular or irregularly shaped target might be. So in terms of a history of radiosurgery, a Swedish neurosurgeon, Lars Leksell, in 1951 at the Karolinska in Stockholm, Sweden, came up with the idea and coined the term stereotactic radiosurgery by being able to rigidly fix a target by skeletal fixation. And so by doing so, by putting a frame device screwed onto the head of a patient, and then using a Cartesian coordinate system directing many beams of radiation to the target, was able to achieve this high dose of radiation to that target. They used a orthovoltage and switched to cobalt radiation source in 1968, and this device ultimately led to what you guys may have heard about called the Gamma Knife. So the Gamma Knife was the first sort of commercial radiosurgery system, and I will show you some of the precursors of that here. So basically, this one was one of the very early kind of crude devices with their orthovoltage unit, where this was sort of locked onto the head of the patient in order to achieve that very accurate dose delivery. So ultimately, the Gamma Knife, which we don't see the full glory of, but it has these small circular collimators through this helmet, and what happens is you you put the patient here, you put the head in this frame device, and these collimating devices will all be targeted to whatever specified lesion one has, and the dose will be delivered very, very precisely, and this is a very, very effective treatment. At Stanford, however, or someone who came to Stanford later, but Dr. John Adler, who spent some time with Dr. Leksell in Sweden during a fellowship, felt that there may be some limitations to that device, the Gamma Knife device, felt that it was fairly crude to be putting frame devices on patients, and thought, is there a way that one could get away from using such an invasive type of technique in order to achieve the same degree of accuracy. So he spent a lot of years here at Stanford in the early 80s, and ultimately, with all of the innovation that's available here at Stanford and all of the bright minds in robotics and engineering, came up with the idea that one could circumvent the need of this fixation by using a robotic device and miniaturizing the conventional linear accelerator. So by that way, one doesn't have to deal with the radioactive cobalt, and so one can use the linear accelerator device. And I'll remind you that Stanford was also the very first place to use a medical linear accelerator in the 1950s. And so I think this sort of builds on that sort of innovation here. And so ultimately came up with this device in which this linear accelerator was made compact and mounted onto the arm of a robot, and then use X-ray sources to image the patient rather than fix the patient in space to deliver the radiation. So what I'll do is I'll go over some pictures over time. This is like about 1994 when we treated our very, very first patient using the rudimentary CyberKnife device, which was at that time called Neurotron 1000. And it went through a few different modifications, some different type of robot with different springs. Then this is probably about year 2000 version of this device, an updated robot, but still looking very mechanical and looking very industrial. And this is about 2003 when it became a little bit more sleek, putting a covering on the robot, on the linear accelerator and the robot arms, but still keeping this configuration of these 45-degree angle imagers. During the course of the treatment, these X-ray devices will shoot pictures of the body part, and then this amorphous silica detector will amplify that image, and that process is repeated throughout the course of the treatment. That information is fed very, very quickly and compared to a digital image that would have been prepared during the treatment planning process. And if there's any distortion or movement or displacement between the actual image and the digital image, then all those corrections are made very, very quickly by the robot or the couch that the patient is lying on to maintain that 1 millimeter degree accuracy. And so this is the CyberKnife that we have today. The main changes are that the imagers are placed in the floor, and these images, so it allows a little bit more workspace for the robot to be able to achieve different positions. And I'll talk to you later about how that opens up some of the newer applications that we've been using. But essentially, the components of the device are the same. Now, I will talk about the synchrony camera later when we talk about tumors that move with respiration. So I know you can envision the idea that fixed objects can move fairly slightly, and if you take enough time, you can always correct for that. But what about tumors that move with respiration? I'll show you how this device can also track that movement. This is an example of what happens during a course of treatment. So the patient is aligned, and this couch automatically positions the patient where we want them to be. These digital images are what we would have had prior to treatment. These are the live images, and there is an alignment process that occurs very quickly before the beam of radiation is delivered. This process is repeated throughout the course of treatment, and those 150 or 200 beams. So it may not image after each beam if the patient is relatively stable, but if they are moving, then one images more frequently. One might ask, what about the radiation dose? It turns out that with the silica detectors, it amplifies the X-ray images, so the cumulative amount of radiation that's given really is much lower than even one CT scan. So given that the high dose of radiation that's delivered to the target is much, much more, we've confirmed that this is a safe delivery. So the main features of the CyberKnife are that it's non-invasive. It allows us a bit more flexibility. So with the frame device, one would have to deliver all the treatment in a single session. Who would want to have a frame on their head for 3 days? So with this, opening up the platform, not having the rigid device, one can deliver the treatment over multiple days. And it then opens up the platform to be able to treat not only things that are in the head region that can be fairly easily fixed, but also outside of the brain. The accuracy is comparable to those frame devices, and we've done many of those studies here at Stanford to confirm that. The non-isocentric delivery allows us to keep the dose very conformal around the target and without compromising the evenness of dose throughout the target. And as I mentioned, we can treat tumors that move with respiration, and there's no need to dispose of any radioactivity such as as with the Gamma knife. So our history, 1994, as I mentioned, the CyberKnife was introduced. We very quickly after the introduction began testing the hypotheses of whether or not we could use this outside of the brain, and started our first spine treatment in 1995. Quickly moved to pancreatic tumors as a proof of principle that we could treat tumors that move with respiration. And then have evolved to treat more lung tumors. It started in 1999, and this program has grown dramatically and has caught on around the world, and so that's a very fast-growing application. The device itself was FDA approved in 2001, so all the patients treated before that were definitely treated on protocol, and actually since then we've kept our protocols open so that we can learn about what the optimal use of the devices are. In 2003, And I think that might be the year, 2003 or 2004, we gave our talk here. And we were just beginning to investigate the use in prostate cancer. And a lot of people were very interested in that potential application. But at that point in time, I really had to hedge and say, you know, I don't want 100 phone calls about prostate because we're really not starting yet. But now I can say it's okay. Okay, so prostate cancer. Liver tumors, we began in 2004. We installed our second unit at Stanford because the program had become very, very popular in 2006, and so now we operate 2 ongoing units at our institution. And then I'll talk to you about some future applications where we go from here. This is just a general trend. In the early years, we really didn't treat very many patients because it was under protocol and still investigational. After the FDA approval, we began to see our numbers increase significantly, necessitating the second device. Now, we've pioneered a lot of different types of treatment. This talk today is about our treatments of cancer, but just briefly, we've pioneered treatments for conditions such as trigeminal neuralgia, which is a very painful syndrome emanating from a sensitive nerve here right off of the brain. And we pioneered a type of treatment different from what they had been doing with Gamma Knife, and found that we could get much more pain relief with this technique. And then some benign tumors of the inner ear where patients lose their hearing, and who, if they're operated on, they oftentimes will lose their hearing and even facial nerve function. We pioneered a technique whereby we could preserve hearing, and we have very, very long-term follow-up of that, confirming those tumors can be adequately treated. Tumors very close to very sensitive nerves that would not have been able to be treated with a Gamma Knife procedure. Here's the vision nerve right in between the eyes here, and the pituitary region, a tumor there that basically nearly touches that. We're able to give the green dose to that target and then have about 50% fall off even within this 1 millimeter of the proximity of this nerve, and be able to spare vision. As shown here, basically this shows you that after the treatment the patient's vision got better and the tumor got smaller. So what we'll talk about tonight, though, is focusing on our applications in cancer. And so these represent the most common applications that we use today. Tumors, brain metastases, spinal metastases, lung tumors, pancreas tumors, liver tumors, and prostate cancer. With regard to brain metastases, this is one of the most common intracranial tumors in adults. It occurs in cancer patients. Up to about 15 to 20% of cancer patients will develop brain metastases at some point, and so that's over 100,000 cases per year. Over 60% of these might have lung masses as well, so sometimes when we see this, we also check the lung. Now, for these types of tumors, if left untreated, most patients will succumb fairly quickly, and if radiation is delivered, we can extend the survival to about 4 to 6 months. And in select patients who are candidates for surgery or who have only a few tumors, they actually may live a fairly long time. These are just general numbers. There are certain patients with specific types of tumors who may even live much longer than this, even with brain metastases. So we felt that this was a very reasonable application for the CyberKnife technology, and one of our goals was to see whether or not we could use this even more uniquely than others had been using this similar kinds of technology. So there's a big study that compared patients with a few tumors with surgery, and asked if you gave surgery and then had radiation afterwards, could that improve outcomes? And it turned out it did. But one interesting factor was that recurrence right at the site of the tumor resection, if you did just surgery alone, this represented nearly 50% of the recurrences, but one could reduce that if they gave the whole brain radiation down to 10%. But we said to ourselves, does that patient definitely need whole brain irradiation? Because sometimes the effects of whole brain irradiation may be pretty striking, particularly in a patient who might live a long time. So we thought, since the pattern of recurrence is largely right at that site where that tumor was removed, perhaps we can use this radiosurgery technology to deliver the treatment very precisely to that area. And if the patient needs to get full brain irradiation at some point later, because of the development of other tumors in other parts of the brain, then we can apply that. So this is what one would do. Here's a tumor in the center of the brain, and this has been removed by surgery, leaving a little hole there and some enhancement. And what we did is we delivered a radiosurgery plan with this green representing this very high dose, our ideal target. And we were able to confirm, and my colleague, Dr. Soltis, who works under me, published this last year, showing that we can get as good local control rates as that other study did with the full brain. Now, what we don't do is we don't end up changing the dynamics of what happens outside of that area. But if the patient developed 3 months or 6 months later other tumors, we could apply this technique again. So many patients are able to defer whole brain irradiation either indefinitely or for a fairly significant amount of time. So we've made, I think, a contribution here. In terms of the spinal metastases, this is another very active area. The spinal column is the most common site of bone metastases, and it causes a lot of pain and neurologic compromise, particularly if it starts to press onto the actual spinal cord. Only isolated cases are actually treated by surgery, so radiation typically is the treatment of choice, but conventional radiation courses last about 2 to 3 weeks. There have been some studies that have looked at giving just a single large dose of treatment versus multi-treatments. They find that they actually get the similar pain relief. However, despite which technique you use, there's a fairly high recurrence rate of the pain. And that's because the radiation dose is very, very limited. And because you're giving the radiation through and through, the amount of dose that it really takes to keep that tumor under control for a long period of time actually ends up being prohibitive because of the normal tissue exposure. So our goal in treating spinal metastases was to increase the biological effectiveness of the dose, so to concentrate the dose so that even though we're giving it in a one or a few sessions, a shorter amount of time than conventionally, that the effective dose of radiation would be higher, and we proposed that we would get similar pain relief or improved pain relief and without having to retreat patients as we found ourselves in before. So this was a review that I did some time ago with 126 patients with 162 spinal metastases, treated over 5 sessions, and we followed them very closely every 3 months. And we had tumors represented in all areas of the spinal canal. And many of the common types of tumors, metastatic tumors from breast cancer, from the kidney, from the skin cancer with melanoma, lung tumors, were all represented. These were the highest incidence. So what we found were 87% actually had significant symptoms, and most of them actually had pain as a component of that symptom. Even though we initially developed our protocol to treat spinal metastases that were isolated to one or a few vertebral areas, what we found were we were getting referrals from all over the country because patients had undergone prior radiation, could not get another course of prior conventional radiation, and were still having pain. And so we were being asked to actually treat these patients. So it turns out in the end, after our revisions, we actually included these patients who had had prior radiation, and in the end, nearly 75% of all these patients had prior radiation treatment. So the important goal was to determine that this was safe and that there was little toxicity, particularly to the spinal cord, in avoiding a patient from being paralyzed. And this is a typical type of treatment. So instead of giving the radiation dose exposure this is blown up very heavily, but this is sort of through the chest. This is the air cavity, we call it trachea, carina, and this is a tumor in the bone of the spine. So this common theme that the green is our target dose around this tumor and vertebral region, and then tightly conforming the dose around the spinal cord so that by this dark blue line is only 25% of what the maximum dose was, and being able to achieve that. And we delivered this over 3 treatments, gave 8 gray times 3 treatments. Typically, when in the outside, if one was giving this with conventional treatments, one could have given 8 gray times only 1 dose if you treated it through and through because of the toxicity. So we were able to give 3 times that dose because we're able to spare the dose to the spinal cord. And so what we found after a mean follow-up of 9 months, and again, that one's just an indication of the severity of this condition, in that I told you earlier, the median survival somewhere around 6 months or so, but our median follow-up was about 9 months. There was several patients living out to almost 4 years with metastatic disease in the spine. So no treatment-related death. 87% of these symptomatic patients actually had improved symptoms. Only 5 patients out of this group of patients had, 126 patients had any worsening symptoms. So we felt that this was a very, very excellent treatment, and definitely proved our proof of principle. In the time since then, some of our other colleagues from other institutions have also published similar results, and some of these are with the CyberKnife, and some of these are with other treatment devices such as the Novalis. But again, pretty good pain relief and quality of life measures. So let's move to lung tumors. In terms of background, standard treatment for early stage lung cancer is surgery, and up to 70% of these patients can be cured by surgery. But about 20% or more actually can't tolerate surgery because of medical conditions, heart disease, lung disease, and so surgery would be very, very difficult. So in that group of patients who cannot be operated on for medical reasons, we have standardly used the alternative of conventional radiation, again in this recurring theme that the sensitivity of the normal tissues kind of limits the amount of dose one can give. And so historically, the overall treatment outcome and survivals actually were only about 10 to 30%, less than a third of patients having good, reasonable survival. And in terms of the tumor being controlled locally, even if the patient didn't die immediately, only about 2/3 of patients achieving some degree of local control. So clearly a place where there can be some improvements upon the treatment. And so this one just shows you patients treated with radiotherapy and patients not treated with radiation treatments in terms of their general survival. So it's, even though this one shows some statistical significance here, probably at the median time frame, as one can see, this has a lot to be desired. So about 14 to 21 months. Now, the potential advantage of the stereotactic in this setting is the highly focused radiation concentrated on the small tumors, single or few treatments, high dose per fraction, very precise delivery using this image guidance I showed you. And even though this historically was confined to the brain, we could move outside. So in terms of our process, for these tumors that move with respiration, we place little metal fiducials into the tumor using some imaging techniques, and I'll show you an example of that. Then also get some information of the 4th dimension called time to see what's going on as the patient is breathing. And we incorporate that in our radiation planning so as to be able to really hone in on just the tumor and not the normal tissues. So this is an example of the fiducial markers, what it looks like here. This is in relationship to a penny. So you can see it's very, very tiny. And this is the scatter one sees from that fiducial that's placed in this lung tumor. Fiducials are made of gold. And so this one was just a brief picture of how that's placed, a needle through the chest wall by our interventional radiologist, and then placed directly into this tumor. And here's another type of fiducial. This one's a platinum fiducial that's made more like a coil. And it's present here and here and here. Okay. And that one also can be used to, as a surrogate marker to be able to see this on imaging. And this is what happens with the tumors that move with respiration. It's a similar technique as what I showed you before, where the images are taken through while the patient is lying there. But as you can see, this patient is freely breathing. And with free breathing, things move. And so how quickly can you check these images and make sure that you've compensated for where the tumor really is? Because one could imagine that by the time you process that information, the tumor has moved to a different spot. So what is unique about the CyberKnife system, much different from other systems, is that we don't make the patient hold their breath and keep it there so that we can image and do the treatment. in one breath hold. That one's a gating procedure. This one's actual tracking. So it develops an algorithm that compares the movement of those internal fiducials and compares it with the movement along the chest wall and creates a predictive model. That predictive model then allows one to be able to track this. And it's updated throughout the course of treatment because one could imagine that the patient can breathe more shallowly or deeply after certain periods of time. And so this is what allows, even during this kind of treatment, that maintenance of about 1 millimeter accuracy in treatment delivery. So we conducted a phase 1/2 study, which really is a study looking at safety and whether or not it's effective in localized non-small cell lung cancers, as well as tumors that had spread to the lung, as long as they were only a few or isolated tumors, in mainly patients who were not able to undergo surgery. In our early days of the treatment, we did have a breath holding technique, and so we did begin this with a single dose given at one time. This has evolved over time, but in terms of this study, 33 patients with a median follow-up of a year and a half, we found that small tumors actually had 100% local control, so didn't grow after that. But slightly different for slightly larger tumors, and tumors that had spread to the lung from somewhere else were a little bit more difficult to be controlled, but still had pretty reasonable control rates of about 60%. And overall survival was about 85% for the patients with the primary lung tumors, but only 56% for the metastases, because most of those patients would succumb to other metastatic lesions. This is an example of the fiducials that are placed in and around the tumor, and we allow a little bit of margin of some of the normal appearing lung because we know the tumor cells don't stop immediately at the edge of the target lesion, and we're able to conform the dose so as to spare dose to normal structures like the esophagus, the airway, the spinal cord, and so they get very, very little dose. And here's an example of outcome. This is before treatment. I showed you this panel previously with this fiducial and the lung tumor. And then after treatment, essentially this was considered a complete response, which means this is only sort of scarring from the radiation that's typically seen, but the tumor itself has been completely gone, and this was proven by metabolic imaging by PET scan as well. So in this study, these are just some of the results. The smaller tumors, just reiterating what I showed you earlier, smaller tumors were controlled well. The medium-sized tumors, not as well, but still very good. And the tumors that got higher dose, the medium-sized tumors that got higher dose, they were controlled a little bit better. And this just talks about the ones that were primary versus the metastatic tumors, and similarly here. So in addition to what we've been doing here at Stanford, other groups have been using the stereotactic body radiotherapy technology and addressing lung tumors. And there was a very nice study in Japan that looked at a group of patients that were inoperable, but they also included patients who were operable, which is a pretty, enticing for us to begin to make that stretch to say, does radiosurgery, can it actually supplant surgery? So far we've been managing most of our patients who could not undergo surgery, but how can we actually compare this to ones that actually can undergo surgery? So with more than 3 years follow-up in more than 257 patients, they found that if they gave a high enough dose, the local control was 84%. With conventional radiation techniques in these types of patients, I showed you that the good controls were about 10 to 30% after conventional radiation. And this is a number after about 5 years. So this is very, very striking. And in the inoperable patients, the number was about 35% at 5 years, rather than that 1 to 2 years that I told you earlier, that was about 10 to 30%. So very, very compelling data, much higher also for patients with operable tumors. And these are those data which concluded that local control and survival rates seem to be superior using stereotactic radiosurgery, most certainly compared to conventional radiation. So I think we've come up with a technology and a technique that probably is going to be a fairly good, close to home run, at least for these patients. There is a trial that's open, and it's one of the first of its kind. It's sponsored actually by the company that makes the CyberKnife, and it's going to be comparing CyberKnife technology to surgery in patients who actually have operable lung cancer. So this is a very intriguing trial. It's one that will serve to give definitive data, I believe, on whether or not radiosurgery can supplant surgery in this setting. So let's move on to other tumor types, pancreas tumors and liver tumors. This is just sort of what's been going on at Stanford. This one was our earlier number in 2007, which goes up. But in any case, we've been pretty active in the pancreatic cancer cases as well. As I mentioned to you earlier, this was a treatment that we initially used as a proof of principle. Can we treat tumors that move with respiration? And we showed that to be true, but we also gained some additional knowledge and insight on whether or not we're actually able to help patients as well. So it turned from a feasibility to actually an efficacy study. This one's just a busy slide, just giving you a little bit idea, just looking at these numbers. These numbers over here are from a lot of radiation and chemotherapy trials for pancreatic cancer, and I think I don't need to reiterate because I know it's in the popular press about how horrible pancreatic cancer can be, but it turns out that about a quarter of the patients, quarter to a half of patients, will suffer some kind of local failure. So it means that the radiation is actually important in the disease, and this contributes to their pain. And so what has been conducted here at Stanford, paying close attention to these last three lines, my colleague, Dr. Albert Kung, has supervised at least 3 clinical trials in pancreatic cancer. First, our first phase 1 study just showing that CyberKnife was feasible and showed that actually in that group of patients they had no local failures over that short period of time. And then in the phase 2 study showed that it was very effective and only 6%. So compare those numbers. And then in this second one where he added additional chemotherapy showed no local failures in that group of patients. And I'll say also that quality of life in those patients was also significantly improved. Many of the patients still succumb to some systemic disease failure in other parts of the body, liver and lung. But this one was very, very encouraging that as a component of that patient's quality of life, that radiosurgery could be effective. And this is just an example of sort of what we do, delivering the radiation very precisely to the target tumor. It's very close to the bowel. This is the duodenum, which is very, very sensitive to radiation, but we're able to conform the radiation dose so that it avoids all of this bowel, avoids the kidney, and even the bowel that's actually in contact with the tumor. So able to deliver that in one single dose. So the major conclusions from these studies was that just a single dose actually was feasible and no significant toxicity. And from the later trials, local control across 4 independent studies, I think we only listed 3, was about 90%. And that stereotactic radiosurgery seems to decrease the pain and prevent some of the complications like the gastric outlet obstruction. And it's only 1-day treatment. So it's one that we are continuing to look at for our patients. Other emerging indications, I told you that we started a liver program in 2004, and we've completed at least one phase 1 study and are slated to open an international cooperative group study looking at liver tumors as well. And also in rectal cancer, we may be considering some treatments, and in esophageal cancer. So this one is just a poster that was recently presented at one of the national meetings with some of the results of this treatment for liver tumors. Now it turns out in liver we can actually treat fairly large tumors, and so that's one thing we learned in our phase 1 study. So we're able to treat these. These tumors respond very, very quickly and nicely to radiation, both metabolically and clinically. And so what we showed was there's very excellent local control of these tumors several years even after the radiosurgery is delivered. So switching to, I believe it's going to be our final topic of prostate cancer. This one's just a picture of sort of what the patient might feel like, but to target the radiation very, very accurately. Hope patients don't feel like they're in that situation, but In the area of prostate cancer is pretty interesting because there is no limit to the treatment options that are out there. So patients can undergo surgery, a radical prostatectomy, and now some devices such as the Da Vinci or laparoscopic techniques are available. So there's multiple surgical procedures. Then there's some radiation procedures, the IMRT I talked to you about earlier. Prostate has been one of the very favored sites of using that technology, and patients have had extremely improved outcome compared to many years ago, where they'd have a lot of problems with diarrhea and urinary symptoms. Now with IMRT, many patients will go through those treatments for 7 to 8 weeks without much in terms of symptoms. Then there are brachytherapy techniques where either seeds are placed within the prostate gland or temporary catheters are placed through the perineum into the prostate gland. Not a very comfortable procedure. Requires anesthesia, and patients come and have that treatment about 3 to 5 times. Not a comfortable procedure, but one that can be effective. So some of the radiosurgery data that I'm going to present is really comparing to what the results of some of these established techniques are, and I think they're very encouraging. And then there's some investigational techniques like cryotherapy. So in these treatment options, there's more than 220,000 new cases per year, and about 40% of these patients will end up choosing radiotherapy. So we asked ourselves whether or not with CyberKnife we could actually improve upon what's going on with conventional radiation. And this is just a conventional radiation course. I told you about 8 weeks. And over time, because of IMRT, we were able to escalate the radiation dose much higher than we were able to many years ago because of the toxicity, and actually have been seeing that we can get better control. So there's a dose-response relationship. If you can go higher in your dose, you can probably control the prostate cancer much better. Here's an example of just showing that we can achieve the same dose distributions as the IMRT using the CyberKnife. So I won't go through it in detail, but basically we can achieve something very, very similar. One thing we've learned about this is what I've just talked to you about, is that you really need, in order to get control of prostate cancer, you need higher and higher doses. And that's all this slide says. There's a bunch of mathematics on here, but that's basically what it states. Now, there's also a unique biology of prostate cancer that has just been sort of uncovering over the last several years. Turns out that we believe that prostate cancer is more sensitive to the dose size rather than just the total dose compared to other tumors. And we believe that there may be improved cure rates and lower toxicity if you give fewer numbers of large doses rather than a large number of smaller doses, a process we call hypofractionation. And we believe that if we can achieve a number that's equivalent to about 90 of the conventional treatment dose, that we can achieve excellent control rates and cure rates. So that's where radiosurgery comes into play. So this is ideally suited for that, giving 1 to 5 large treatments. And radiosurgery in this case would also replace HDR, which is that high-dose brachytherapy where catheters are placed in. And you can use it with the CyberKnife, or there are other techniques of using linear accelerator-based radiosurgery. And it's non-invasive. I did not include the slide that shows you how invasive the other tumor is, the other procedure is, but just suffice it to say that this is much less invasive because it only requires just the placement of those fiducial markers, but not catheters through the perineum and anesthesia. And so this one was a courtesy of one of my colleagues down in San Diego, who has also been showing that the radiation doses achieved by these radiation dose placed directly into the prostate, we can actually achieve that with the CyberKnife. And this one was very, very hard for people to believe, because how can you get much better than putting the dose right in the prostate? And so it turns out that with the newer technology of the CyberKnife planning, we can actually achieve a dose distribution that looks just like having the radiation seeds and catheters in the prostate. So this is very encouraging, and there's a study that's ongoing now looking at at this technique as well. So we can increase the dose very safely, hopefully keep the same late effects, and reduce any acute effects, and reduce the treatment to a week and a half. So this is Dr. King's work here at Stanford, Dr. Christopher King, and he's delivering the dose in 5 fractions. He pioneered this work, was the very first person to deliver radiosurgery for prostate cancer. And so everyone has been definitely awaiting his publication of this, and I'm happy to say. And this was a preliminary review up through August, 45 patients, up to almost 4 years follow-up, and really showed that the prostate-specific antigen, which measures the activity of prostate cancer, quickly goes down and naders very, very quickly over the first couple of years, which is very encouraging. And this is a paper that everyone's been awaiting, currently in press, and I think will receive a lot of interest in the medical community. He was able to show that the quality of life with regard to urinary symptoms, rectal symptoms, and ease of treatment was very, very favorable. So concluded that the early and late toxicity profile and the PSA response for prostate SBRT are highly encouraging, but believes that we should continue to accrue and follow up patients, as with all the other studies, and to see if this is durable. And I think that if it is durable, I think we've found a very, very new and exciting treatment of prostate cancer. And so just to compare, IMRT, very, very good treatment. That's what's considered standard right now in the radiation therapy community. 8 weeks compared to radiosurgery, a week and a half. You're giving, well, we put the costs here, so there's a little bit of cost difference. It's very expensive treatment all the way around, but pretty comparable with very little time. And so for many busy people, time is very, very important. So maybe that costs something. So what about some of our future directions of this CyberKnife radiosurgery technology? I believe that many very common cancers we will be forging a frontier on. In terms of breast cancer, we have not begun to treat the primary breast tumors just yet, but there is a lot of interest that is swelling around the use in breast cancer. And so we hope to tell you sometime in the next couple of years that we're beginning to explore that a little bit more. Some of the technical issues with the machine, I think, were some of the initial limitations, but now with the open platform, I think we may be able to forge that frontier as well. We've begun to look at other tumors like this uveal melanoma, which is a type of eye tumor, and usually they put radioactive plaques in directly into the eye in an operative procedure, or take the eye out altogether. And so this is a way in which we could potentially save the eye and be able to treat the tumor effectively. This is courtesy of one of my colleagues in Munich, Germany, who has already begun to pioneer this kind of work, and we're considering working with them in the near future. But this one's an example of a patient's tumor being treated by CyberKnife radiosurgery, and then after treatment, the tumor essentially gone. And so at 8 months follow-up. So we believe this is sort of an area of potential exploration. Other areas that our colleagues here have been very interested in are non-cancer types of treatment for even things like depression and mental illness. And so those are things that are coming through the pipeline now. We've begun to also treat some other non-malignant conditions like back pain. This one's just on a protocol, and again, we pioneered this sort of work here. We're not sure exactly which way this is going to go, but this has been proved to be fairly effective in the patients that we've treated so far. So again, I'd like to thank you for your attention, and I also hope to come back here again in the next several years and report that we're even forging the frontier even further. Gliomas, particularly malignant gliomas like glioblastoma multiforme, is a very, very difficult disease to get to be treated with any type of technology. But yes, we have actually even conducted a clinical trial using the CyberKnife and an agent called arsenic trioxide to improve the radiation's effectiveness in patients whose tumors had come back after conventional treatments. And we found that that was safe, and it probably bought the patient some period of time, but it is not a cure for that disease. But it can be used in that setting if it's recurrent. The answer is yes. Our group here so far has not explored that in depth, but I can assure you that there are many CyberKnife users across the country who have begun to use this technology, particularly kind of similar to the lung tumors, where there are patients who might not be able to undergo surgery and who have a kidney tumor and it's isolated. The question is whether or not you could use this technology in a way that's similar to surgery, and so some of my colleagues across the country have been using that. And just to mention to you that since the time that I met the first time and gave this lecture, there have been a proliferation of CyberKnives across this country, and so you'll find that many folks are using this in slightly different ways. But still, a lot of the pioneering work in most of the tumors have been done here at Stanford. Actually, it's successive. So each beam is delivered, and then it shifts to another position and delivers the radiation dose to the next position. It is possible because obviously if one delivers a treatment, a very long treatment with multiple beams, it could be over a period of an hour. With simultaneous treatments, one could deliver that in a matter of seconds. And then what the biology of that simultaneous delivery compared to the sequential one and time factors are unknown right now. But I can assure you that people have raised the issue of whether or not we could deliver the beams in a little bit more efficient way, and that actually has come to fruition. It's not a simultaneous beam, but the company has developed a device called the Iris, not named after me, even though that's my first name. Basically, it's a device that instead of using single circular beams of radiation, actually allows one to use a range of collimating devices of different sizes. So most of those beam delivery, if you use one collimator, each beam will be collimated exactly similarly. With this device, it can change depending on what area of the target is, so the treatment actually ends up going faster. And so we might get a little information about that once this Iris collimator is being used, and currently ours is being installed as we speak. Okay, thank you all very much.
For more, please visit us at stanford.edu.